know if any of you are aware of NCIP, or the National Consultant Information Programme, but I'll whiz through some slides. I'm happy to share these afterwards. So because there's quite a lot of detail on a lot of them. Not sure how long we've got, so please tell me to hurry up if you want me to go a bit faster. And if you've got any questions, please, yeah, just ask away. So to just give you a very sort of whistle-stop tour of NCIP. It's a portal or a tool that's for consultant surgeons across England. It was designed to be a single source of data that covers the whole practice of support for quality improvement. So it's been designed for consultant surgeons to be able to have all their sort of procedural data in one place that they can use for a variety of reasons, for appraisals, revalidation, for quality improvement. It can be used for clinical audit or M&M meetings. So there's a variety of reasons that you could use the data, but it's the usefulness of it, it's in one place. So as it says on the slide, it's a free platform for consultant surgeons across England. At the moment, there are 15 specialties that are live across the tool, and at the moment there's just over 10,000 consultants across the country that can actively log on and see their own data. As it says on the slide, it's for consultant surgeons, but it's also there for clinical leads, responsible officers and MDs. So they're the only people that can see the data. And at the moment, there's 130 trusts across the country that are actively involved in NCIP. The last point, and we will come on to that in more detail, but the data that's within the tool is primarily HES data, and we use ONS and SUS data as well, but Tina will go into more detail on that shortly. So as I said before, it's a free platform, and it's there for you to locally and nationally benchmark the data, and it documents all the activity over a set period. So if you go into the tool, there are set sort of periods of time, so you'll be able to see which procedures you've done, the volume, and it also pulls on various kind of statistics, whether like length of stay, readmission, and you can also drill down into things like demographics and comorbidities. So there's lots of useful information in there for consultants to be able to pull on and use however they feel necessary. So as I say, some of the key uses, as I've mentioned before, that it can be used sort of for leadership and oversight. So it's there for clinical leads to be able to use, and they can see the data for all of their unit and use it for planning going forward or for sort of quality improvement projects. It can be used individually for their GMC appraisal, their trust appraisals and GMC revalidation. It can be used for clinical governance, and as I said before, it can help with pathways, so clinical pathways. So there's some of the specialties are using NCIP as a data tool to try out new procedures, new surgical techniques to see if what the impact it has been on length of stay or readmission. So there's various ways that you can use NCIP, as I say, from a quality improvement point of view or from reviewing pathways and pathway management. And then finally, as it said before, it can be used for data quality, and it identifies any sort of inaccuracies around PAS and clinical coding. So we rely on the HES data that the individual trust put into there, but of course that's not necessarily always attributed or accurate. So there's ways that individual consultants can go in there and see their data and go back to base and get the accuracy sorted out if there is an issue. So as I said on the first slide, and I'm racing through for you, there's four kind of main areas that main sort of users of the tool. It's predominantly used for individual consultants, but as I say, it can be used by clinical leads for an oversight of that particular surgical unit, and it can be used by responsible officers and medical directors at present. It is a free tool. It's not commercial. Was never designed to be a performance management tool. It's always been designed to be a tool for learning and for quality improvement. Although as a team we can see all the dashboards and all the data, we're not there sort of looking at the data day in, day out. It's down for trust and individual consultants to look at their data and maximise the use of the tool in whatever way they feel fit. And the final point is that it's not open to the public. It's not been designed for the public to see this data. It is only purely for the individual trusts, consultants, and those 4 user groups that we've mentioned before. Tina, do you want to go on this one? Because you might probably do more justice than I will about the data side of things.
Yeah, sure. So the way that we developed NCIP originally, we're going back about 4 or 5 years now, was that effectively the model is that we have a clinical lead from the specialty itself. Very often they are part of the specialty association. There might be a president, an ex-president, etc., or have some kind of specialty leadership role. Sometimes they're GERFT leads, sometimes they're actually dedicated solely to NCIP. And then we have a triangular type approach. So we have somebody like Heather, who deals with the deployment and adoption with trusts and clinical users, responsible officers, etc. And then we have somebody like me who works on the data and the algorithm in the back end. And then we have obviously our clinical lead. So in effect, it's developed by clinicians for clinicians. The specialty associations are very useful in some ways because, of course, they generally tend to hold the clinical audit data. So where there is a clinical audit for that particular specialty, we're able to try and match to see whether or not our data is close to that. And that's actually been quite invaluable in terms of the accuracy and the developments, the accuracy of the data we use in terms of writing the algorithm or the recipe, as we call it, so that it encompasses the varying different coding variances that happen between units and trusts, etc. Obviously, we've got national clinical coding standards, but they're not always followed. And NCIP is the only place in the system at the moment where we look at this in great detail, and then we develop clinical coding guidance, as does GERFT, off the back of the work that we do on the data analytics side of things. The main thrust of the NCIP portal content at the moment is surgical. There's some interventional content in there, but it's primarily surgical. The view is over the long term that this will, for all various different professionals, anyone who's clinically managing a patient or a case, will have access to an NCIP set of dashboards built for them by their specialty. The part of the reason it started with surgical, as you can probably imagine, it's really easy to count. We've got tariff, therefore we've got generally good data that sits in the PAS that gets exported to SOS and therefore developed into HES. And generally speaking, some of the data quality around things like consultant attribution, the coding depth, etc., tends to be much better than in some of the medical specialties. Sorry, there's just one thing back on that slide again. Sorry, Heather. Excuse me, everything we put out is anonymized, so I cannot see any details of patients, etc. And there's also things like small number suppression. These are things that we're working through, so that in order for the tool to be useful for you for things like M&Ms, for example, having the anonymous record isn't necessarily helpful if it's a high volume procedure, for example, that an M&M will be looking at. So there are things around some of the de-identification and some of the information governance aspects that we're still working through, so that we have a product that does what it needs to for each of the different user types. The important thing to remember is that because it's HES and ONS, that's where we get the mortality data from, is that all of the data refreshing happens in the back end. So there's no user front end in data entry of any kind. There is a little bit of work that's happening around theatres, which we'll talk about essentially when that becomes closer to the user data entry, but otherwise the data sources require no manual addition. And you also, as a user, as a consultant user can then look at their clinical audit data compared to the HES data, because if we've done our jobs right, we should get them pretty close together in terms of those volumes. And if it isn't, we've got some clear explanations as to why that is. And that's really one of the added value about the way that NCIP develops its recipes and data matching work. Next slide then, please, Heather, thanks. So one of the questions that we've got for you, or one of the requests we've got for you, is around data quality. And I'll come to this a little bit in a minute, but as we've kind of touched on, although there are national clinical coding standards, for example, you will know that they're not always adhered to, either through legacy, just available staff, etc. Things like laterality are common codes that get missed, etc. for various different reasons. We have trusts that will have all of their clinical coding recorded in the 24 positions, the OPCS positions in their submission to SOS, and in some cases, obviously, because it can go up to 99 in terms of the clinical coding system and the PAS, actually sometimes procedures go past that. So these are the sorts of things that we're encountering when we hear from clinicians who say to us, look, your numbers are all wrong, you need to go and get your numbers right, and these are the factors that we're finding out. This means, of course, because we've got a clinical coding team within our team, we're immediately responsive to finding these things out, for example. So and that particularly helps with clinical coding guidance as an interim step before it becomes part of the main national clinical coding standards, which of course is the training program that all clinical coders follow. The basis of how we then do the count for a consultant is we use the main specialty in HES, which is derived obviously from the SUS data, which comes from the PAS. In HES, as you'll probably know, and SUS, only one consultant can be allocated to an FCE or a finished consultant episode because of that data, the way the data is structured. This poses a few challenges in contemporary team-based practice, particularly in a lot of sort of more general and larger surgical specialties, because the consultant a patient sees in outpatients is not necessarily going to be the consultant who then follows up and operates on them. Slightly different in some of the smaller specialties, but in the high volume, bigger specialties such as urology or general surgery, that's not necessarily the case. That then, of course, is where the attribution question comes in, which we'll come back to in a second. The theatre data quality aspect that I mentioned earlier is that various EPRs either have their own theatre data module where data entry happens immediately after the procedure has finished, the patient's gone off to recovery, and the surgeon or surgeons can then enter the data actually there and then on a terminal within a theatre. That's not always possible for everybody, and that system isn't always connected. And in some cases, the data entry that happens in theatre is to the clinical audit system and is not to the EPR and therefore the PAS. So GIRFT are doing an extensive amount of work with on a theatre data programme, which currently trusts are submitting data to voluntarily direct from their theatre module or a theatre system such as Blue Spear, etc. And then that allows a greater depth of data quality that comes from that system that, of course, HES and SUS don't have, because we're now asking HES and SUS to do something they were never built to do. By putting those two data sets together, it gives us a richness and a depth and a greater accuracy of data, and that work is underway now. Once we are happy that that's of a sufficient quality, NCIP will then bring that data into its portal dashboards so that users actually get to see that kind of deeper, richer picture. The other thing I should say is that where a procedure happens, which I think Heather was saying earlier, if it's NHS practice, whether that's in a private unit or whether that's on an NHS hospital site, that is included. If it's private practice on an NHS site, that is included. But cases that are solely private practice within a private unit are not yet included, because the FIN database is something that will get pulled into NCIP. We're just not there yet. It's on that very long to-do list, as you can imagine. And then the final thing is that some of our reports are already available through Model Health System at unit level. So as a consultant, not necessarily be able to see, but at a unit level, then a consultant would be able to, or group of consultants could go and look at the unit level practice within Model Health System interface as well. Next slide, please, Heather. So in terms of the data quality side of things, and this is where we start to really ask those of you who work in acute units to become involved if possible. What we're saying here is that we know that in HES and SUS there are data quality issues. Some of this arises from things, as we've said, clinical coding variances. Some of it arises from, as we know, PAS teams over the years have historically been underinvested in, and in some cases they've lost their data quality team. And in the view that the EPR is kind of taking over some of all of that, I think most of us who talk to PAS team leads know that that's not the case, and that they've generally got concerns about superseding a PAS with an EPR, when the controls that were originally around PAS systems for many, many years were designed to help with data quality in terms of some of that accuracy side of things. we do have, so business rules, etc., to help with that. But where we have issues around workflow, there aren't necessarily things in place in trust to be able to deal with that. Now, last week we heard of a trust where all of the surgeons put their own data in after they enter all their data after their surgery onto the EPR. And the other thing that also happens is that they also have write-back rights to the PAS system, so that if the outpatient consultant is still on the screen as being the operating consultant, they then change that consultant to themselves, and that writes back to the PAS, and then it comes through Accurate. We've looked at that at our end, and it does indeed show a change where the consultant has changed from the admitting consultant to the operating consultant. Obviously, it means there's a few more FCEs in the spell, but the point is that the operating surgeon is actually accurate, so the attribution is correct. In terms of a product like NCIP, the attribution to the consultant is quite critical, because the counts for the consultant on their dashboards should be as what's reflected in their logbooks. In terms of that FCE and that one-to-one allocation of a consultant who would be considered a primary operating surgeon or the responsible surgeon, because we have a one-to-one match in PAS, HES and SUS, which is main specialty consultant, that is where NCIP is looking for your help, because in order for that attribution to happen correctly, it means that some groups of clerks, or indeed surgeons, depending how many units work, require that right back access to the PAS. And that's not an easy thing, where historically, and rightly so, many PAS teams have held on to the control of the PAS data to make sure that it's accurate when it has the XML extraction into what was NHS Digital into SUS. We know that there are some configuration aspects that can happen with an EPR where certain clerks can have right back access, and therefore improves the attribution in the PAS. We do know, for example, that ward clerks in many trusts, when they admit a patient under a consultant, although the module will show the admission module will show the consultant of admission, the PAS will not have had its consultant change, because there's no right back facility in terms of the configs between the EPR module and the PAS. So that's one aspect that we're looking for your help with. A second thing is around accurate clinical coding. In terms of in some cases, either lack of coders, historical practice, some local and financial arrangements and tariff that have been agreed, sometimes just not having enough people to do the job, etc. We do notice that there are variances in clinical coding. Now, we know there's variance in clinical practice, but we want to get to a point where we've got true variance in clinical practice, as opposed to a reflection of coding variances that are indicating there's variance in practice. So this is kind of that first big step. Because we've got clinical coding within NCIP and GIRFT, we're able, as I said, to issue clinical coding guidance, which generally most heads of clinical coding are interested in taking up and following, because it makes their life easier. It means that they get the standardization without having to do any work at all. Obviously, part of this is reassuring finance directors that what we're not looking to do is to upset tariff, because of course that would be a potential consequence. And because we've got clinical coders who do this work in NCIP, it means that we're getting it from the horse's mouth without any concerns to finance directors and consequences for tariff. The third aspect is that we've got a data, and where we're going through this quickly, so we'll go through some of this in more detail if need be. The third aspect is the data quality toolkit. Off the back of some of the work that we've been doing in various different specialties, etc., we have developed a data quality toolkit. A clinical director said to me one day, he said, I never undertake this procedure. It's not a procedure that I do, my team don't do, but because I'm the consultant on call at the weekends, then I am the consultant who this procedure then gets allocated against. And despite many conversations, he never cracked it in terms of trying to get the correct consultant allocated to that particular FC in the PAS. And he wanted to know how he could do some more work in it. So off the back of that and a few other conversations, we created a data quality toolkit, which is in that link, access the data quality toolkit there. And it takes a consultant user through, a clinical director user through, how to start the conversation. Because it's really difficult to go up to a door of clinical coding and then not know what to say. The toolkit actually starts to help with those conversations, and also has content in there to reflect the confidence that a finance director also needs, that no one's interfering with, upsetting the balance of tariff, etc. Next slide, please, Heather. So in terms of the ask of you, this is kind of it summarized. One is around data quality. So that is that consultant attribution aspect and some of the challenges that we face in terms of write back, access, and interface between EPRs and PASs. And then, of course, where there are restrictions or issues around that, some technical interface issues, that then means there's a consequence of potentially what does that mean for the PAS team in terms of improving the accuracy. And your roles as the straddlers of the clinical digital interface, if you like, are probably the most placed to have these conversations. And I'm aware that some of you might be gulping as you're saying that, but we're quite happy to support you with this as well, because we've done some work on how some of these aspects are problematic. The second thing is also working with the digital clinical team, so usually sort of head of digital or a config lead, etc. And again, looking at some of those technical interface issues, so that we're not suggesting that all EPR modules need write back access to the PAS, but certainly the operating episode definitely does for something like NCIPs and GERFs, to make sure that where we're actually counting, we're counting correctly and we're attributing correctly to a particular consultant. The other aspect, the next aspect then, is around that clinical digital leadership. So this is about assurance and influence, all of the things that we've spoken about before, as well as supporting a medical director in the rollout of this. As Heather said, that the 130 trusts NCIP is in at the moment, to varying degrees, etc. And obviously that kind of interface role that you and your teams have would be quite key to this, as well as having those conversations with what was the PAS team lead, etc., the data quality team, the all PAS data quality team, etc., to understand better how we can influence some of the changes in local trusts. The other aspect is also around supporting head of clinical coding, about establishing and using clinical coding libraries. There are ways of copying those across from one trust to another. There's also documentation that exists around standardization in addition to the national clinical coding standards. And of course, there's clinical coding guidance that comes out from GERFT. That can all seem a bit sort of coming from left field, but we haven't yet spoken to a head of clinical coding who's not willing to take this up. They're just looking for a bit of support with it, really. And of course, they generally report to the finance director as opposed to the medical director. And then in terms of the source documentation, whether that's a piece of paper, whether that's something that gets recorded in a theatre module, etc., is to improve the quality of that information that's recorded. One of the complaints we hear, for example, from clinical coders is that laterality is often not recorded. Some procedures it doesn't really matter, but for other procedures it does matter, because when we're looking at readmissions and reoperations, obviously looking at laterality is quite key in terms of understanding whether it's a true reoperation or whether it's just the next stage of treatment on the other side, etc. And then the final ask of you is that if it's possible, that you as a group would be happy to in effect act as a kind of a reference group for the work that we're doing in NCIP and GERFT, because of course you can constructively critique, etc., and shape what we're doing, point us in the right direction if you think we're going in the wrong direction, etc., so that we develop some of the insight that you have and then develop ourselves accordingly, etc. Next slide, please, Heather, which I think might be you.
Yeah, the next are kind of just sort of additional information, really. So as I say, these are the specialties that we've launched to date. As Tina pointed out, majority of them are surgical, but we are looking to get more into interventional areas in the near future. But that's where we've got dashboards and we've got data behind them at the moment. And then the next few slides was just a reminder, as Tina said, that a lot of the NCIP data is available in Model Health System. So for you or people that are non-surgical, you can still get into a lot of the NCIP data via the Model Health System. And it was just to highlight that you just select your hospital, select acute hospital services, and then the specialty you want to, and then you can drill down. And at the bottom of the page is where the NCIP cards are, to be able to see some of the NCIP provider data. So it's basically there for you if you want to use. But just to reiterate what Tina says, that it'd be great to sort of get your support and be as some form of clinical reference group for us as we progress the tool further. That's it, really. So there's more detail on the website, and if not, email us if you want some more information. But no, thanks for letting Tina and myself come and talk to you today.